Thank you, Dr. Adil. Also, I would like to introduce our first presenter today, Dr. Jameel Rasheedi. Dr. Jameel Rasheedi, he is a consultant in neurology, specialized in stroke, neurocritical, and intervention neurology. Dr. Rashid also he is a member of education and research subcommittee. Dr. Rashid, today he will talk about guidelines of intracranial hemorrhage. And so, Dr. Jamil, you have 30 minutes to start. Thank you.
Bismillah. طيب, we'll discuss today, inshallah, the guideline for the intracerebral hemorrhage. And I have no disclosure. So we'll go through the guideline source, guideline review, and some other guidelines, and then I will come. That's okay. And then we'll end with take-home messages. These are the most commonly and well-known organizations that publish guidelines for ICH, the American and Heart and Stroke Association, the Canadian Stroke Best Practice, the European Stroke Organization, and the Neurocritical Care Society. 2 Americans, 1 Canadian, 1 European. So far, we have the most updated guideline is the American Heart and Stroke Association, published 2022. We have the Canadian Best Practice guideline, published 2020, and European Stroke Organization general guideline for ICH was a bit old, 2014, but they have published a recent guideline answer specific questions regarding the blood pressure management, published in 2021. And then another guideline, 2019, is specifically only for reversal of oral anticoagulant. And then the Neurocritical Care Societies has also 3 different guidelines that also discuss points related to the ICH management. So for the sake of the time, I will just review and discuss and present the American Stroke Association guideline, and if there is any disagreement between the 2 different guidelines, then I will mention it. So as a general introduction, ICH is the worst form of acute stroke, and they have a mortality reach up to 40% and then represent a greater public health burden globally. The incidence of ICH increases sharply with age, and therefore it's expected to remain substantial. And that's because of the cerebral amyloid angiopathy and the atherosclerotic disease process in elderly. And also due to the fact that increase the use of anticoagulant and the new development of the new anticoagulants. And this update on the previous guideline published 2015. This one focus on the primary, secondary prevention and acute phase treatment of the ICH and the post acute phase rehabilitation recovery, as well as they published a new recommendation regarding the use of the image and risk stratification based on the image. Worth to mention that this guideline only take in consideration isolated primary ICH, not related to underlying vascular pathology such as vascular malformation or ICH related to aneurysmal rupture or hemorrhage related to neoplasm, as each of these diseases has its own guideline. Okay, it's important to understand a bit about the pathophysiology in order to implement the guideline properly. So in this guideline, they discuss the management in the ICH as well as the interventricular hemorrhage, which will be referred as IVH. So they go through different phases. And so we can see here that there is first phase acutely, there is a risk of hematoma expansion with which lead to secondary brain injury due to edema and mass effect, and then end up by developing perihematomal edema, which also worsens the secondary brain injury. And this will be eliminated if the patient goes to surgical intervention. The IVH could be primary, I mean, like isolated IVH, they still consider it as ICH, or it could be an extension of the ICH. So ICH present with IVH. So okay, we will go through different questions and points. In terms of regarding organization of the hospital and initial assessment of the care, there is a class one evidence, class one recommendation with high, good level of evidence that recommend these. There should be awareness and education to the care provider, and the use of the stroke, acute ischemic stroke scales in the pre-hospital can improve the transfer and early initiation of the management for this patient population. And the centers that will receive this kind of patients should have the capability of providing expert consults with and neurocritical care team or stroke team, as well as neurosurgical intervention capabilities. In terms of physical examination and initial laboratory assessment, strong recommendation with moderate level of evidence that history, physical exam, routine labs with shown here should be obtained and performed in the initial assessment. And then we go through the neuroimaging. So they strongly recommend to have a rapid neuroimaging, whether CT or MRI. And then class 2A recommendation with a moderate level of evidence to obtain CT within the first 24 hours and frequently to so the CT can be done in the first 24 hours after the symptom onset to evaluate the hematoma expansion. And if the patient presents with low glass coma scale or neurological deterioration, then a serial of CT scan is useful to evaluate the hematoma expansion or hydrocephalus or brain edema or herniation. And then a CT angiogram, there are some CT markers that can be used to evaluate the risk of hematoma expansion. One of them in the CT angiogram and the others in the non-contrast CT. And there is a recommendation to use them for risk stratification for the hematoma expansion risk. And these are the markers. So we have the swirl sign, the regular margins, the blend sign, fluid level, black hole sign, non-contrast CT, and then we have the spot sign in a CT angiogram. And this is the ICH score, which we'll discuss later. It can predict the fatality rate, 30-day case fatality rate, and it includes glass coma scale, ICH volume, whether there is associated IVH or no, and the location, whether it's infratentorial or supratentorial, and the age of the patient. So strong recommendation, again, if the patient is having ICH and age less than 70 with posterior fossa or infratentorial ICH, or age less than 45 with infratentorial, and to obtain a history of hypertension, no history of hypertension, to obtain CT angiogram plus consideration of venogram. And a patient with IVH and no detectable parenchymal hemorrhage, so isolated IVH, it's recommended to have DSA, which is a catheter angiogram, cerebral angiogram. MRA as well can be used, and if the patient has a negative CTA or CT venogram, then it's also recommended to obtain a DSA, as well as performing MRA to look for cerebral myeloid angiopathy or deep perforating vasculopathy like micro-AVM, cavernous malformation, or malignancy, because these lesions do not appear in the DSA. If the DSA is negative, then it's recommended also to repeat it within 3 months interval. For acute blood pressure management, they recommend with class 2A level that blood pressure treatment should be in a sustained manner. So avoid variability, as variability turn out to increase the worse the outcome. And the treatment should be initiated within the first 2 hours and reach the goal within the first hour. And if the patient present with blood pressure, systolic blood pressure between 150 to 220, then they recommended the target blood pressure to be around 140, ideally between 130 to 150. Is it safe and reasonable to improve the functional outcome? If there is a large severe ICH and requiring surgical decompression, then the safety and efficacy of intensive blood pressure lowering is not well established, and strong recommendation against lowering the blood pressure below 130. So this was the American Association guideline. The European Stroke Organization guideline says that in the first 6 hours, it's recommended to lower the blood pressure below 140 and keep it above 110 to reduce the risk of hematoma expansion. Moderate level of evidence and weak strength of recommendation. And they published consensus agreement that should be initiated within the first 2 hours and not exceeding more than 90 millimeter mercury lowering from the baseline, and should be maintained from 24 hours up to 72 hours. In terms of anticoagulant-related ICH, if a patient on vitamin K anticoagulant and INR more than 2, then they recommend the prothrombin complex concentrate over the fresh frozen plasma to correct the INR. And vitamin K also should be administered. This is class 1 recommendation, good level of evidence. And if INR between 1.3 and 1.9, it's still reasonable to give the PCC to prevent a risk of later on increasing the INR and hematoma expansion. For the oral anticoagulants, they recommend to use the reversal agents for each different anticoagulant. But if they are not available, then they recommend to use the PCC. And for the idarosuzumab, for the dabigatran, if not available, then renal replacement therapy could be considered to decrease the medication concentration. For the heparin, protamine can be used to reverse the unfractionated heparin effect or partially minimize the effect of low molecular weight heparin. And this is a scheme for the mentioned guideline in terms for anticoagulant-related ICH. For the antiplatelet use with the ICH, If the patient on aspirin, then platelet transfusion might consider to reduce the post-operative bleed and mortality only if the patient going for emergency neurosurgery intervention. The rule for desmopressin is uncertain, and they recommend against use of routine platelet transfusion if the patient is not going for any surgical intervention. So again, no clear rule for the use of recombinant factor 7, and no established good data for the use of tranexamic acid as well. So strong recommendation to admit these patients in a stroke unit or highly specialized unit with a multidisciplinary team and a center that has the capability of surgical intervention. And if they require transfer from a hospital to another hospital and they are under they are in a status of instability hemodynamically or unprotected airway, then this should be stabilized before any transfer. And if they don't need ICU admission, then admitting to a stroke unit is better than admitting to a regular unit. And admitting them to a neuro-specific ICU compared to general ICU is recommended, and should be admitted to or transferred to a center with a neurosurgical capability as well for either ICH or IVH cases. So they also recommend the units take care of these patients to develop a standardized protocol and order sets, and to perform dysphagia screening protocol before administering any oral intake, and to provide cardiac monitoring for the first 24 to 72 hours. Looking for infection as well is recommended. And start of the DVT prophylactic in form of intermittent pneumatic compression should be started from day one of the diagnosis. And then low molecular weight or unfractionated heparin prophylactic doses can be started 24 to 48 hours. And they recommend strongly against use of compression stocking alone. And if they are not eligible to, or there is a contraindication for a pharmacological use of DVT prophylaxis, then retrievable IVC filter could be used. And if the patient has indication for therapeutic anticoagulant for DVT or BE, then should be delayed or postponed for at least 2 weeks, 1 to 2 weeks after the onset of the ICH. For glucose monitoring, they recommend to start terphening if the blood sugar is more than 180 or 200. And euthermic should be the target, and there is no clear rule for hypothermia to improve the outcome. If the patient with ICH and unexplained consciousness and there is clinical seizure, then drug for anti-seizure should be started. And if suspecting seizure, then EEG should be applied for continuous monitoring, ideally more than 24 hours. But they recommend against use of routine anti-seizure without evidence, electrographically or clinical evidence of seizure. So patient with ICH, IVH, and hydrocephalus that contribute to decreased level of consciousness, EVD should be performed to reduce the mortality as a class 1 recommendation, strong evidence. And the use of early prophylactic hyperosmolar therapy is not established. And if it will be used, then the bolus regimen is preferred over the continuous regimen. And they recommend against use of corticosteroid as a treatment for elevated ICP or edema. And if the patient present with supratentorial ICH more than 20 to 30 ml volume and low glaucoma scale, then hematoma, minimally invasive hematoma evacuation is strongly recommended to improve the mortality and outcome compared to medical management alone. And this is this scheme for IVH treatment. So minimally invasive treatment for IVH is also recommended if there is IVH volume less than 30 and there is decreased level of conscious despite placement of the EVD, with or without thrombolytic treatment through the EVD. So weak recommendation for the use of craniotomy, which is just opening the burr hole instead of doing the minimal invasive evacuation of the hematoma. But it can be used as a life-saving. So ICH patient who deteriorate neurologically and have brainstem compression or hydrocephalus and cerebellar ICH more than 15 ml in volume, immediate surgical evacuation of the hematoma by posterior fossa decompression with or without EVD is recommended. And then when ICH patient with a coma who have large hematoma and significant midline shift or elevated ICV, refractory to medical management, then decompressive craniectomy with or without hematoma evacuation should be considered. And it's the same as for supratentorial and infratentorial as well. So the use of score, the ICH score that I presented earlier, should not used alone as a decision making whether to proceed for aggressive treatment or no. And withhold aggressive treatment or assign the patient as a DNR should be postponed at least until the second full day of the ICH. For the rehabilitation, so early discharge is encouraged to improve the 3-month recovery, and start the rehab within the first 24-hour and 48-hour is recommended, and they recommend against start early rehab within the first 24-hour. And there is neutral effect of fluoxetine to improve the outcome, but if the patient has a depression, then this is another indication. So long-term blood pressure control should be ideally below 130 to prevent the recurrence of the ICH. And then statin pharmacotherapy is of uncertain efficacy and against use of long term of NSAIDs because they increase the risk of recurrence of ICH. And if a patient has AFib and indicated for anticoagulation, then should be postponed from 7 to 8 weeks. And with that, we go to the take-home messages. So regional system should be developed and patients should be rapidly transferred to a unit with neurosurgical capabilities and expertise. Hematoma expansion associated with worse outcome, and then the use of neuroimaging markers help to predict the hematoma expansion. Use of different modality, CTA, CT venogram, DSA should be used to identify micro and vascular pathologies. And limited blood pressure variability as a is known to worsen the outcome, and sustained blood pressure control to reduce the hematoma expansion is recommended. Anticoagulated ICH patients have extremely high mortality and morbidity and should be reversed. several therapies that show no efficacy and no benefit and should be avoided, as we mentioned earlier. Minimally invasive procedure for evacuation, whether of supratentorial ICH and IVH compared to medical management alone, is effective to reduce the mortality and improve the functional outcome. And then the decision to implement any intervention should be shared between the physician and the patient. And severity scale should not be used alone to take a decision for the treatment. Rehabilitation should be started within the 24-hour to 48-hour and should be avoided within the first 24-hour. No effect of fluoxetine on the functional outcome, but it might reduce the depression. There is risk of increased fracture with the use of fluoxetine. So the patient's home caregivers should have the support practically and have practical and psychologically and provided a training in this area.